thank you to the National AIDS Memorial Team for hosting this year's World AIDS Day National Observance. It is an honor to be here with you, co-presenting this conversation series with our colleagues at the National Hemophilia Foundation. Before I share a little bit about BioMarin, I would like to recognize all of you and how you supported one another during a very dark time for the bleeding disorders community. I can only imagine the profound loss that you have experienced because of the 3 H's, hemophilia, HIV, and HCV, and the devastation that it wreaked on your community. We are humbled by your fortitude and the stories of your lives that demonstrate profound strength that comes from unthinkable tragedy. We have lost an entire generation of adults with hemophilia, but in today's panel, you will hear from some of the survivors who were able to thrive in spite of the odds. I care deeply about the many people who are part of the BioMarin community. Our community is growing, and I hope that in time you may consider yourself as part of what we are trying to do. While we are new to hemophilia, we have been blazing scientific trails in rare genetic diseases for more than 2 decades. What we are doing is hard. The scientists and physicians at BioMarin are focused on treating the root cause of a disorder, and they are asked to do nothing less than change the treatment paradigm. It is bold, and the people who work here would not have it any other way. I guess you could say that we take pride in solving hard scientific puzzles. We only develop treatments that can be first and or best in class. Bold science on its own, though it is not enough, we are motivated by connecting bold science with those who may benefit from our treatments. We are fortunate that our work is purposeful because of people like you. Thank you again, and now please join me in welcoming our special guests for this important conversation.
Hello all, my name is Patrick James Lynch, and it is my honor to be hosting this World AIDS Day conversation titled A Generation That Survived, the Hemophilia Community and the Crisis Emerging with an Aging Population of HIV/AIDS Survivors. And to be doing so here at the warehouse where the AIDS Memorial Quilt and all 50,000 plus panels of it are stored. As you can see, we have behind our panelists here some of the quilt pieces that are specific to the hemophilia community. Quite a powerful setting for this conversation on what is a powerful day. The conversation today is going to be built around a study called Navigating Time and Space, Experiences of Aging with Hemophilia, a study funded by the National Hemophilia Foundation Innovative Investigator Award, which examined the lived experience of people 50 and older aging with hemophilia and, for many, concurrent HIV/AIDS diagnoses. The research highlights a growing issue in America, the plight of HIV/AIDS survivors and a generation who thought they would die, but lived. Joining me for this discussion on the study, its findings, and their significance are CEO and President of the National Hemophilia Foundation, Dr. Len Valentino, Sarah L. Schwartz, a social worker and clinical associate professor for the University of Southern California. Sarah is also a board member of the National AIDS Memorial and one of the lead authors on the study. And Bobby Wiseman, person living with HIV and hemophilia and dear friend. Thank you, Bobby. Thank you, Sarah. Thank you, Len, for being here. Before asking Sarah to share a bit about the report itself, Len, I'm interested to know why NHF chose to support this study in the first place. Do you and does the foundation agree with the very way this conversation is framed, that there is an emerging crisis of people with chronic illnesses who are living longer than they thought? And what does that crisis look like if we don't take action to stop it from escalating?
Yeah, thanks, Patrick, and thanks for having me on World AIDS Day. This is really exciting, and I think this conversation is so overdue. In general, the U.S. population is aging, and the baby boomers who were born between 1945 and 1965, essentially, have all grown and are aging. And I think it's because of the advancements in treatment for HIV, many people who were infected with HIV, have AIDS, have really survived and thrived with those new therapies and those new treatments. The same is true for hemophilia. the life expectancy for men with hemophilia and women who are affected has really improved over the course of time because of comprehensive care, prophylaxis, and new treatments that have become available. So we're seeing a population that we never have seen before, aging men and women with hemophilia. We don't really understand what to expect. And Sarah's study, this type of work, is so important for us to really understand what the issues are. And it all, again, focuses back to what additional research needs to be done. What's the education that everybody needs around aging? And importantly, what advocacy issues can we address and help support this community to ensure access to mental health care, to medical care, and those new treatments that are available? So I think it's a really important topic that I really applaud Sarah and her group for doing this research.
Thank you, Len. And Sarah, with that, congratulations on the work. And as a person living with hemophilia, I am personally appreciative of your focus on our population and, as Len said, this issue that very much so needs the attention that you've given it. I read in the results of the study that 88% of the participants report that their unexpected longevity has affected them in profound ways. What are some of those profound ways that people have been affected by their unexpected longevity?
Well, thank you for having me here today. Yes, this study illuminated that the majority of our aging people with hemophilia never expected to live this long. So for the majority of the people in our study knew their shortened life expectancy as children, had grown up not thinking they would live beyond their late 20s or 30s. Changes in treatment expanded life expectancy, but then HIV contracted it. And one of the key findings was that many of our individuals never planned to live this long. They had lived their lives week by week. You know, maybe this week will be my last week, which meant career development. Some are struggling financially, hadn't planned for caregiving. Many didn't have children. So that was one of our findings, that they're navigating this adulthood or older adulthood having never anticipated being here.
Are there any other findings that particularly stuck with you or surprised you as you went about the work?
A really interesting theme that emerged from the data is that many of these individuals are moving into caregiving roles, which is something that they had never expected. And this has been a beautiful experience because they are now providing care for the people who had cared for them. In many cases, these are parents or spouses who have helped for decades. And this is rewarding for those who are having this experience.
Bobby, I hear you responding a little bit as you hear things shared from Sarah. I want to kind of go back to my first question to Len a little bit. Do you feel as though that you're living through an emerging crisis?
That's a packed question. Sitting here, World AIDS Day, sitting with the quilts, remembering certain things, remembering to not remember, and emerging through a new thing, as this lovely young lady here stated, the switch of caregiving. Like, my mom has finally been, diagnosed bleeding disorders, some things going on there. That shift, the shift of why certain things happened and didn't, and how to go through that, of why I had the opportunity to keep going. The opportunity, as discussed earlier, treatment and new emerging things. And to be a fluffy 50 in a place where there are the fluffy 50s in the quilts, and getting through all that, and that next piece of, as it's been alluded to, the mental health piece, that so directly speaks to overall health, that so speaks to our community that has dealt with a hell of a lot and still is, and now at a point of saying, what can we do together collectively, and calling some stuff out and addressing it directly so our communities remain united, that we don't have to have a negative quote unquote thing to make us all stay together.
Crisis can be so binding, but we shouldn't have to rely on it to bind us together.
Right, because we're all, see, I'm going there. See, it's World AIDS Day. It's not just the hemophilia piece. We all got stuff going on. And this is where it's like, okay, we know it's here. How do we deal with it? Yes, it's a crisis. But in crisis, at the end of it, there's the word is. What is it that we can do? What will we do? And how are we all going to do it together? So that we don't have to have the sorrow of it all. That we can say, yes, this issue is going on. Yes, there are mental health needs and various levels of it. Not all of us may want to address them, and that's okay.
You're speaking very well to the kind of the big picture of the moment. Personally, you shared the caregiving role a little bit with something that resonated. Are there other ways that your unexpected longevity has impacted you?
The unexpected longevity is that now going into different levels of care, that I wasn't expected to be past 12, then 15, then 35-ish, and having to deal with a system of care that's not ready for me because they're like, wait a minute, you have hemophilia. You have no technical joint issues, this, that, the other. What do we do? You're coming colonoscopy. You know, there's like, oh, we got to coordinate with the hemophilia. We haven't done this before. And it's this whole thing of looking at, okay, if I do have to go into long-term care eventually, what does that look like? What does it look like when going, life insurance policy? Like, wait a minute, you're still living. What does it look like when saying, oh, you mentioned earlier, okay, so now 401k starting to build. It was not on the concept to have a savings account. It was not on the concept to say, invest in this. Because it was like, the hell with it, basically. I'm going to be dead. And now it's this whole thing of, I may be here till I'm 85, crotchety and old, and having a good old time.
Fluffy 85?
Fluffy 85 and looking good, too.
Thank you, Bobby.
Yes.
Appreciate your honesty. Sarah, there's a list of 5 recommendations to support this current cohort of aging persons with hemophilia. And one of the recommendations is enhance mental health support and access to those aging with hemophilia. And as I read the recommendation, I think much of what's in there is relevant to those aging with HIV, regardless of a hemophilia diagnosis. And I want to read just a portion of that recommendation. Our study identified themes of trauma, shame, stigma, and cruelty that wound. In addition, this cohort has faced a series of unparalleled losses, and due to the medical and social histories, complex histories, we recommend securing access to experienced mental health providers, as many individuals aging with hemophilia may offer socio-emotional complexities with intertwined family histories due to the genetic component of the disease that emerging mental health professionals may not be able to fully address. So Sarah, as a social worker, as one of the leads on this study, what role does complex trauma play in this aging population's experience of getting the care that they need here and now?
I think Bobby spoke to quite a bit of this trauma this community has experienced, starting as children with lengthy hospitalizations, keeping them out of school, social isolation, bullying, stigma, pain. I think that can't be overlooked, the enormous amount of physical pain that individuals with bleeding disorders experience, particularly those who live through the changes in treatment, who are over the age of 50, and the emotional consequences of physical pain. It's so complicated. And then when HIV and AIDS came on the scene, many of these individuals hid their identity, their hemophilia identity, because of homophobia and stigma and what happened to, Ryan White was all over the media, and the Ray brothers. And so then there was this, this identity, a shared identity through summer camps and through other people you knew, then you had to hide it. And many of the people I've interviewed have just started kind of stop hiding, they're just beginning to not hide anymore and starting to unpack their trauma and the effect that it has had on their decisions in life and relationships. And this research study was a partnership, was a academic and provider partnership. Dana Francis with UCSF's Hemophilia Treatment Center has been a full partner in this study and has educated me and Tam Perry at Wayne State University on this complex trauma and why we need to tap into the wisdom of this older generation to help educate our up-and-coming physicians, social workers, nurses, physical therapists on this history.
So, Len, I want to shift gears a little. If there's something about complex trauma or that you've heard you want to comment on, I invite you to. But I want to ask you a slightly different question. As we're talking about mental health services in particular and the enhanced mental health services, I can't help but think about access and insurance and barriers to people achieving that. And I wonder, is it even remotely possible to have those kind of enhanced mental health services for those that need it at scale? How can the National Hemophilia Foundation utilize this study and the powerful anecdotes that are within it to create some real change on the policy front, the programmatic front, or educational front, or the like?
The National Hemophilia Foundation has actually created 5 priority focus areas. And those 5 priority focus areas include what I consider to be underserved populations and problems that we have. Von Willebrand disease, future therapies and knowledge about those future therapies, rare and ultra-rare bleeding disorders, digital health technologies. But I think the most important one in the topic of today's conversation is mental health. We've talked about mental health for a long time, but we don't have the providers equipped to be able to fully assess and then provide intervention and referral. We haven't established the partnerships with the appropriate professional mental health organizations that can help us take this to the next level. So we're looking at mental health in all of these priority areas through the lenses of provider education, consumer education, public policy, payer relations. Getting these things paid for and ensuring access is incredibly important. And then, as Sarah's doing, research. What is the research that we need to do to propel this community forward and deal with the mental health issues? You know, one other thing that Sarah was getting to, and I think is a real problem that we haven't really dealt with, is what I would consider survivor guilt. You know, as a child, the boy with hemophilia whose sibling dies because they have an intracranial hemorrhage or they have uncontrollable bleeding after surgery, or the person with AIDS who survives and is a long-term survivor, but their friends and their family members have succumbed to HIV. I think that survivor's guilt is something that we have not really recognized and certainly have not dealt with. The mental health trauma that comes from that, I think, is enormous.
And not to interrupt, and the survivor's guilt of a caregiver.
Exactly.
Case in point, my mother who infused me. Mm-hmm. That's never talked about.
Right.
That piece. And then the flip is now I'm going into caregiver mode and slowly addressing that. Or even our providers who have been there with us for years and that have seen some of us decline and not and dealing with all that. Mm-hmm. And yes, that's one type. And then that other survivor's guilt of the what's next, if that makes sense. Mm-hmm. And it's all that it's just there. And especially for World AIDS, it's that piece of how do we start dealing with that? Yeah. It's similar to you talking to the providers being equipped. What is also the care for the providers? What is the care for our community when we're trying to say there's some pains in there that have not been really talked about? Right. Nor the part when you know what it could have been as opposed to what it is. And then the part when, as you say, the access and the pieces of that, when our community members are going to get to saying, I want to get this done, yet bureaucracy gets in the middle. Mm-hmm. And this long process, 45 days to wait till you see someone. And then you're at that cliff to make a decision. What do you do? All right, I'm sorry.
Bobby, you brought something up that I think is profound, to use a word from earlier. And it's this idea that there's some unspoken pieces that connect to this guilt that, tell me if I'm wrong, what I hear you saying is that now as the role is changing, when you are the caregiver to your mother, that unspoken thing that's been unspoken for a long time has to be addressed. Am I hearing you correctly?
Yes, because that my mother's that she said several times, when her purpose is fulfilled, she's going on to her eternal rest. And part of that is dealing with certain things. You know, for roughly 8 years, she's the one putting the needle in the arm. And at that period of time, knowing what happened. And then that next piece for me being a half a century, and my lifting summer camp and various other things of my translation over to that education. That's, yes, the bleeding disorder piece is part of it, but that piece to say, let's talk about the real shit. Excuse my French, I'm going there. That the shit of, you're dealing with this. How do you get to that next piece? That, yes, all this may look bad. You can't have the job you want. Don't go into a substance side or this. Let's try doing this. Okay, you have some mental health issues. Let's really talk about it. Let's not do the thing of just suppressing it and keep on going. Or when you're hanging out with your buddies at wherever, then you talk about it. Let's talk about the angst in our community where some don't have access to certain things and which propels into other things. Let's talk about how there's regional differences that do bind us all together. Let's talk about how do we really make some change to where we can all go forward, to where none of our communities having to look back, woulda, coulda, shoulda. That's where we're at right now. Yes, we've dealt for 40 years the HIV piece. Yes, for many years the bleeding disorder piece. And now it's the point to say, okay, we know what this is all going on here. How can we do it? Okay.
Thank you, Bobby. I know that I've heard the executive director of the National AIDS Memorial, John Cunningham, talk about the healing nature of the memorial and all of the work that's done. And as you talk about what conversations have yet to happen, it seems as though part of this aging population, part of the consideration involves what conversations are yet unsaid and maybe running out of time to be had, because there are those you are caregiving for and their time horizons and what they're in that timeline. So I'm really glad you spoke to that, and I appreciate the way you bring your vulnerability forward. Thank you, Bobby. Sarah, I want to go back to that recommendations list for a moment, if I may. We talked about the mental health piece, and there are 4 other recommendations. And I'd like to mention them each and then give you an opportunity to respond to the final one. Recognize the variation within those aging with hemophilia. We could just as easily say HIV. This is not a monolith. There are many different experiences and subsets to consider. Recognize that changed time horizons lead to new identities and new social roles, and we've discussed that as well. Promote visibility of all genders living with hemophilia. Hemophilia does not just affect men. That is an antiquated and incorrect idea. But this is the one I want to give you a chance to expand upon a bit. Continued visibility of the history of this cohort. And as we have Bobby here sharing with us so openly, the history feels alive. I mean, we're in this extraordinarily powerful setting. We have an amazing storyteller. I feel the history alive. But we have to make the effort to continue keeping it alive. And I wonder if you could share a little bit about the Surviving Voices video that we're going to play at the end of this conversation, and that I know had an important impact on you ahead of your starting this work.
So I have been involved with HIV as a volunteer with HIV and AIDS for a very long time. But I had no understanding of the connection with the hemophilia community until we created the Surviving Voices video at the National AIDS Memorial in collaboration with the HIV Story Project, where I used to serve on a board. So that, as someone who has been active in the HIV and AIDS community, learning this new history blew my mind and shamed me that I didn't know this history, and completely pivoted my work with the National AIDS Memorial towards documenting the history of the hemophilia community, the hemophilia in connection, the community in connection with HIV and AIDS. That study led to our Hemophilia Memorial, which is in the Grove. And it really, I think, created bridges between the AIDS community and the hemophilia community that we intend to continue to develop in the future. There's a ton of work to be done.
Well, to the point of there's a ton of work to be done, and we're coming up on our last few minutes. But Len, I want to talk about partnerships because as mentioned at the beginning, this was a grant that was enabled by the NHF Innovative Investigator Award. And as Bobby calls out some of the specific work that needs to be done and some of the challenges to access, it's too much for any one person or any one entity to take on. Could you maybe share a little bit about how you and NHF think about working with people like Sarah and working with places like the National AIDS Memorial and partnerships that help this population as we have identified there is a crisis and a need to spend more time? How do you think about the way partnerships come together?
Yeah, so for me, partnerships come from having a community. And that word has been used multiple times, community. And really it's bringing the community together, all aspects of the community. And what I think is most important is some of the work that people like Sarah are doing is to get the voices of the people who live with these disorders and diseases. It's the lived experience that's so important that we really can then leverage. And we talk now not about patients, but we talk about subject matter experts. Who can be more expert in their disease than somebody who lives with it for their life? So I think that the real partnership then is created by an organization like NHF being able to pull the community together, galvanizing around a particularly important topic, and then being able to put resources behind it to be able to get the work done. And I really look at this as some really important work that we need to continue to promote, continue to fund, and continue to make as visible as possible. It's a super important area that I really think that we need to continue to work very hard to understand the challenges that people who are aging with hemophilia, aging with HIV, and just aging in general. Our healthcare providers are aging as well. How do we continue to support them? We have no clue. So this is really new territory for us. And I think it's all about putting the community together and bringing everybody together to speak with one voice.
You mentioned that providers bit. It just strikes me, those who were working with patients with HIV through the 80s and the 90s and the early aughts, and we're all aging. And so we lose some institutional knowledge and experience, lived experience from those providers as well, which isn't something we had discussed thus far. So I'm glad you made that point.
I've been part of this community for 40 years. I came in as a healthcare provider in 1980. And, I've seen the changes that have evolved, but I haven't seen the support evolve for certain parts of the community, including the support that, the mental health of our healthcare professionals. We've seen that tremendously during COVID and the impact that COVID has had on the healthcare professionals. But we need to make sure that we can support healthcare professionals just as much as we're supporting those subject matter experts who live with these diseases.
So speaking of subject matter experts, as we wrap up our conversation just ahead of playing the Surviving Voices video that Sarah was just discussing a couple of moments ago with me, Bobby, I want to thank Len, Sarah, and you, Bobby, all for participating. But I want to give you the final word, because as we sit here on World AIDS Day, and I think about the struggles and the journeys of all people with HIV, affected by HIV and AIDS, when I think about the gay community's struggle within that struggle, when I think about the Black community's struggle within that struggle, when I think about the hemophilia community's struggle, to state the obvious, you sit at quite an intersection, my friend. Mm-hmm. And your honesty is unparalleled. So, if there's one thing that you would like those who are listening to this conversation on World AIDS Day to take away from this dialogue, what would it be?
The power of choice. And what I mean by that, I was alluded to earlier, the institutional knowledge of our providers, the institutional knowledge of our subject matter experts who've lived through it, the ability to have that voice spoken. And the quilts are a wonderful remembrance, but what hit my mind of the storytelling, it doesn't necessarily have to be in the quilt. It could be our community members getting together, making a cookbook that has a recipe, but in that there's that story, so it goes on down. It can be a artwork or whatever, that sitting here, Quilts, World AIDS Day, what has impacted me right now is there's division that's going to come together. As alluded to, are females with bleeding disorders, are clinicians who are aging, systems that are now being made to change that gives everyone access, everyone choice. So my final words would be choice, because then you have an option of what to do, and you're in control of that. You have that dynamic, the choice to advocate, the choice to speak up, both from a clinician standpoint, for his or her own needs, to support subject matter experts to render the warm and fuzzy and not warm and fuzzy to those coming up, to have the rough conversations, provider to patient, to say our silos of I'm this organization and you're that one, that got to go. The choice to say all of us in community need to be together, whether gay, straight, plurple, murple, whatever, Baptist, Catholic, whatever. That has no relevance to it all. What's relevant is that at the end of the day, what is done that is right for our folks who are coming up. The education piece of saying, you have an option. If you can't do it this way, let's try that way. And to remember, yes, there are those who are on our national forefront for years who have gone on home to glory. But the ones that are behind are going to give the glory to the ones who are coming up in that choice. To remember, the struggle got us all where we're at today. Because without the struggle, all of this wouldn't be happening. All of conversations wouldn't be happening. World AIDS Day with our community would not be happening, because it's necessary to continue that knowledge that says our community has fought for so many others, and so now we're going to continue with collaborations so that we can continue, so that our folks don't have to be on a quilt. But when they do go on home, it's not because of complications, because they had a decision and they made it. That's my final choice.
Those are some powerful words, Bobby. Thank you very much. And thank you all for watching this conversation. Enjoy the rest of the conversations as a part of this World AIDS Day celebration. Thank you.